can diagnose, differentiate the air fluid level, whether it's a hydropneumothorax, that is air and fluid pocket together in the pleura, or whether it's a lung abscess or a necrotizing lung lesion, that is an abnormality inside the lung. Do you know how to do that?
Yeah, maybe changing the position of the patient, lateral decubitus.
You're nearly there. So you do a frontal X-ray and then you do a lateral X-ray. Now, if it is in the pleural space, the air fluid level, the width of the horizontal fluid level will vary in the frontal projection and lateral projection. So you can see that's a narrower width in the lateral projection. It's a wider width in the AP or frontal projection, and because of that, it's in the
pleura.
It's in the pleura. Very good. Yeah, it's in the pleura. It's not in the lung.
Yes.
Okay. So, do you want to comment on the CT? Can you identify the corresponding air fluid level that you saw on X-ray? Can you see that on CT?
Yes, there is an elliptical separation of the right basal pleura with fluid level and overlying consolidation, as well as
consolidation. Yeah, there is fluid level.
Yes.
So what is this? What is this now? What's the pathological term for that?
It's an encysted empyema.
Yeah, it's an empyema. Yeah, because that's in the pleural space now. Now there is something else that will tell you why this happened in this person.
So, okay, I will try to analyze the rest of the images.
Just look at the lung window.
Okay, so on the lung window, there is a fistula.
Yeah, there is. Very good. Yes. So what is that fistula called?
A bronchopleural fistula.
There is a bronchopleural fistula. Because of the extensive infection, the lung and the bronchial tree has broken down and is forming a fistulous communication into the pleural space, and that is why there is empyema there. So it's bronchopleural fistula causing hydropneumothorax and empyema. Yeah, so bronchopleural fistula. Chest X-ray appearance: persistent hydropneumothorax with air fluid levels asymmetric on frontal and lateral views. Central bronchopleural fistula usually post-op. Peripheral bronchopleural fistula can be from infection or inflammation secondary to underlying abscess, necrotizing pneumonia, bronchiectasis, and TB. Peripheral bronchopleural fistula can also be a mass, a malignancy that undergoes necrosis and breaks into the pleural space, or it can be barotrauma, where the lung explodes and forms a fistula into the pleural space. So you know what bronchopleural fistula is now, and look out for bronchopleural fistula when you find hydropneumothorax, and look out for the communication of the lung air or the bronchial tree. You may not actually see a bronchus communicating into the pleural space. You'll only see a communication, a break in the lung parenchymal tissue in BPF on CT. So this is what I was telling about how to differentiate based on the width of the air fluid level. A lung abscess, whether you see from side or from the front, they'll have the same width, whereas an empyema or a hydropneumothorax, which is air and fluid in the pleural space, if you are looking at from the front, they'll have a shorter width here, whereas if you're from the side, this will have a longer width.
Mm-hmm. So this is frontal chest radiograph of a skeletal mature patient. I can see there is slight, the aortic knuckle is small. I know this is not the theme of...
Sorry, say it again, I didn't get that. Say it again.
The aortic knuckle is relatively small, but I know this is not the theme of the presentation. So
aortic knuckle is fine. In a young patient, you don't expect a big aortic knuckle.
Okay, so nothing caught my eye on primary survey, so I am systematically reviewing the film. The mediastinal contour is alright. Yeah, there is right upper zonal opacity.
Yeah. So you cannot not pick up these opacities in the lung. That can be a cancer, that can be an infection. In this case, this is post-primary TB. This is a classical site of early appearance of post-primary TB, where you see in the upper lung a little bit of consolidation, which will gradually develop into cavitating consolidation and large cavities. So on CT, you can see nodules and inflammatory changes and tree in bud. I can see some tree in bud. Can you see the tree in bud here?
Yes.
Yeah. So small nodules budding out from a structure called tree in bud appearance.
Okay. So I can see bilateral multifocal patches of ground glass opacities as well as consolidation. There are also some fibrotic or reticular opacities, mostly in the right upper zone.
Now, the lung is undergoing a scarring process. You know that,
Yeah.
isn't it?
Yes.
The lung is, the hilum is pulled up. I can see linear strands here. So this is undergoing a scarring process. Now, is the scarring process an interstitial fibrotic process, or is it a parenchymal destructive process?
I think it's more of parenchymal destruction.
Yeah. So what are the causes that results in this kind of parenchymal destructive process?
TB.
TB, yeah, very good. And
yeah, histoplasmosis, maybe.
Yeah, which we don't see in this country at all.
Yeah.
Sarcoid.
Sarcoid, yeah.
Yeah, yes, TB and sarcoid. So, yeah, can you elaborate a bit more? What is happening here?
So I can see maybe this is a cavity.
Very good. That's a cavity. There is no lung markings there, vascular markings there. So that's a cavity, and there is a pulled up right hilum on, and this is right apical cavity. Quite classical for post-primary chronic TB. Okay.
So I can see hyperdense, very extremely hyperdense extrinsic or pleural-based opacity over the right upper zone. It looks like it's heavily calcified.
Yeah.
I can see that the overlying chest wall is abnormal. I cannot see any other pleural plaques.
So how would you put the diagnosis for this? It's a calcification in the
pleura, apical pleura.
Yeah. So calcified
pleural plaque.
Is this how pleural plaques appear?
Yeah, it's not the typical appearance, but I agree.
That's because it's not pleural plaque. Pleural plaques have typical appearance of leafy, edgy calciums with central lucency. This is a heavy, dense calcification in the pleural space, and you can call this a calcified fibrothorax.
All right.
Right? That's the term you can use for this. It's a dense calcified structure. Usually happens from TB, from infection, an empyema. A long-standing empyema will develop calcium along the wall. So a sequela of infection, a sequela of a traumatic big pneumothorax, etc. So calcified fibrothorax. This is not pleural plaques. Please don't say pleural plaques. Yeah, you have seen at least 2 pleural plaques today.
All right.
Okay, that's a fibrothorax, calcified fibrothorax. Next one. Do you want to change, or do you want to continue? We have done.
Yeah, I would like to continue if you're happy.
Yeah. So we'll do. I think we have done half an hour for you, 12 cases. So okay. To be fair, I think we should change to the next person. Is that okay?
Right. Yeah, it's fine.
Thank you.
Thank you.
Yeah, can number 3 raise hand, please? Number 2, please mute yourself. Number 3, can you speak? Is number 3 here?
Can you hear me?
Yeah, I can hear you. Are you number 3?
Yeah.
Very good. Thank you. Can you start with this X-ray, please?
Frontal chest radiograph with bilateral dense opacities, especially on the right side. There appears to be cavitation within the opacity. The lung appears a bit emphysematous to me. There's a tenting of the both hemidiaphragms. So that shows that there's some fibrotic process going on. Mild interstitial thickening process, thickening as well, especially in the lower zones. So these appears more like a background interstitial fibrosis and bilateral mass-like lesions.
Can you see reticular opacities anywhere?
It's more scarring than the reticular opacities.
Exactly. This is a parenchymal scarring process.
Yeah.
This is not an interstitial fibrotic process. You correctly picked up the tenting of the diaphragm, and those lines are actually fibrosis. When lung scars, when there is inflammation, after inflammation, there is scar tissue, and that's how it appears. Just pulls the diaphragm up, pushes the diaphragm up. There is parenchymal scarring process. There is no reticulation at all. There is no reticulation at all at the bases. And the basal volume is not reduced. You did say that the lungs appear hyperinflated and emphysematous. So when you say the rest of the lung is hyperinflated, how can you put IPF in the differential? How can you put interstitial fibrosis?
Yeah, you're right.
Yeah, go ahead. Yeah.
So background scarring of the lung. Now these two bilateral hyperdense lesions. Initially, I thought about progressive massive fibrosis.
Yeah, that's a good thinking, because perihilar large consolidation is the appearance of progressive massive fibrosis. But progressive massive fibrosis usually a bit more upper mid. That's a good thinking. Yeah, Go ahead.
Other differential I was thinking of background lung infection.
Can you see air crescent sign here?
Yeah, I can see the air crescent sign, especially on the left side, which is very evident.
Good. So why didn't you say that?
So aspergilloma in background TB maybe is one of the differential, because the lung is quite scarred. So
there is cavitating process. Yeah, there are multiple cavities with fungal balls inside.
Mycetomas.
Yeah, so you should say cavities. You didn't say that. I can't read your mind. The examiner will not be able to read your mind as well. So there are cavities with fungal balls and air crescent signs. So are the cavities in the upper lung or mid lung?
In the mid lung.
Right. So what are the differentials for cavities, fungal balls?
The cavities, the fungal ball can develop into previously formed cavities from tuberculosis, but here tuberculosis are typically upper lobes. The other differential would be vasculitis cavities, and then patients immunocompromised, and then developing these mycetomas in them.
Right. This is sarcoid cavities with fungal balls. Okay. If you see cavities in the center, think about sarcoidosis. And there is so much chronic scarring process going on. I wouldn't think of an acute abnormality like PCP pneumonia or invasive aspergillosis at this stage. Also, although you can mention that, but this is not the appearance of. I'll show you pictures of how the invasive aspergillosis cavities will look like. So this is chronic cavities, a lot of chronic scarring, and there are fungal balls in the cavities.
It's a frontal chest radiograph with a central line. I can see the central line in the patient, right-sided. The tip is projecting, I think.
Yeah, ignore the central line, that's fine.
So that means patient may be having a long-term chemo or antibiotic therapy.
Yeah. Pick up the abnormality in the chest, in the lungs.
In the left side of the lung, behind the heart, there is some.
Very good. You're all getting extremely good at picking up retrocardiac hidden area abnormalities. There is consolidation behind the heart in the setting of a probable immunocompromised patient on central line, and I'll give you the CT.
Yeah, so the CT is showing reverse halo sign.
CT showing what sign, sorry?
Reverse halo.
Reverse halo, is it?
Yeah.
It's proper halo. I mean, it's not reverse halo.
It's not reverse halo. Because
I don't know why you said reverse.
Yeah, I don't know.
It's a halo sign.
Yeah, it's a ground glass opacity around the soft tissue opacity.
Exactly. Yeah. So there is ground glass opacity surrounding that nodule, pulmonary nodule surrounded by ground glass. There is ground glass around that nodule. There is a little bit of ground glass here as well. So diagnosis is?
Invasive aspergillosis?
It is invasive aspergillosis. I'll just show you the magnified picture which shows ground glass around that nodule. Now, for a better understanding, I call it angio-invasive aspergillosis. Then I am always thinking about angio-invasion and the hemorrhage and the pathomorphology. I usually say angio-invasive aspergillosis. So it happens in immunocompromised patients in severe neutropenia. It can also happen in immunocompromised with normal count, but they are immunocompromised because of heavy steroids. What happens is invasion and occlusion of small and medium-sized pulmonary arteries, resulting in necrotic hemorrhagic nodules with halo sign, or they can also result in pleural-based wedge consolidations, which are actually pulmonary infarcts. So multiple nodules with surrounding hemorrhage, halo sign, or multiple pulmonary infarctions. Those are the features of angio-invasive aspergillosis. Halo sign is nodules with hemorrhage. It can happen in angio-invasive aspergillosis, candida and mucorales infections, cytomegalovirus, and Kaposi sarcoma. These are, you might get a case of Kaposi sarcoma in your long case. So if you find nodules with halo sign, remember to keep that in the differential. Do you want to do this X-ray now next?
Yeah, from frontal chest radiograph, the patient has got a central line in with the correct position. I mean, an endotracheal tube with the correct position. There are ECG lines up, but the main abnormality is bilateral air specification in both mid and lower zones.
Yeah. You can say they are consolidations because you can see air bronchograms within them, no?
Yeah.
Yeah.
So it's patchy consolidation bilaterally, or in fact rather diffuse, I would rather say, in both mid and lower zones. It's quite typical of atypical bacterial infection. It could be there could be very different differentials. So atypical or viral infections. Again, there is soft tissue nodularity with probably some air crescent sign.
Air crescent sign.
Yeah.
So there is air crescent sign on a background of extensive lung consolidation. Diagnosis?
Aspergillosis.
Yeah. So as you correctly identified, said earlier, air crescent sign can happen in acute invasive aspergillosis as well. So I'll show you. It happens during the resolving phase of active infection. What happens is, lung tissue is dead and necrotic. It forms a ball inside a cavity. So this is invasive aspergillosis, air crescent sign. And usually the air crescent in invasive aspergillosis surrounds the entire soft tissue, whereas the mycetoma or fungal ball is along the superficial part of the cavity. Now I'll show you the next X-ray, which is same patient 2 weeks earlier together. So there is quite a lot of consolidation in this radiograph, but no air crescent. And then the consolidation is resolving, and at that time the air crescent sign develops. So do you get it? Air crescent can happen in chronic fungal ball in a cavity. It can also happen in the resolving phase of invasive pulmonary aspergillosis in immunocompromised patients. So crescent sign can happen in chronic fungal bore as well as in angio-invasive aspergillosis. In angio-invasive aspergillosis, it happens 2 to 3 weeks after the halo sign during the recovery phase. Next.
So it's frontal chest radiograph. Patient has got endotracheal tube and some other line as well, which I can see L-shaped.
That's probably an ECG lead. It's not something.
Okay. There are multiple bilateral rounded opacities of various or nodularity of various size throughout both lungs. They are larger than the miliary nodule, I would say.
So this is fairly. These are Acinar nodules. Do you know Acinar nodules?
In the alveoli?
Yeah, in the alveoli, because they are kind of non-uniform in size. Some of them are coalescing and quite extensive. Differentials?
Metastatic lung?
Metastasis is a differential. It's quite unusual that patients would survive to this degree of lung metastatic nodules. Lung would compromise and they would... Sorry?
Histoplasmosis, coccidomycosis, but they would be smaller?
I've never seen histoplasmosis in this country. Varicella pneumonia. Varicella pneumonia, this degree of acinar opacities is a kind of a classical appearance of varicella pneumonia. Okay, so keep that in mind. Is that okay?
Yes.
Acute varicella pneumonia, extensive and widespread acinar opacities. So the learning points are how to identify acinar opacities, how to distinguish the distinct nodules of miliary TB and the slightly larger but still distinct nodules of subacute hypersensitivity pneumonitis, and how to differentiate the appearance of sarcoidosis, etc., from a case like this, where it is a widespread acinar opacity, acinar nodules coalescing into opacities in acute varicella pneumonia. Okay?
Yeah.
So acinar opacities, 4 to 10 millimeter, ill-defined, coalescing, non-segmental, air bronchograms or air alveolograms may be present. Differentials are pulmonary edema, unusual pneumonias like TB, fungal, PCP, varicella, viral, pulmonary hemorrhage, trauma, bleeding disorders, DIC, Goodpatcher syndrome, idiopathic hemocirrhosis, fat embolism. Fat embolism usually happens 2 days after post-trauma. They're usually peripheral acinar opacities, and they resolve. Normal heart, skin and neurological abnormalities may be present. Metastasis, lymphoma, bronchoalveolar cell carcinoma, sarcoid, and low flow syndrome, which is usually a larger consolidation. Next case.
So frontal chest radiograph, the abnormality, you can see there is increase. There's a paucity of vascular marking on the right side as compared to the left side, and there is increased bronchovascular marking, especially in the left upper zone and mid zone.
So lung vascularity is decreased. Which lung is abnormal?
I think right lung is abnormal.
Yeah, and what's the diagnosis? Which hemithorax has larger volume?
The left side has got larger volume.
Good. So small, relatively less perfused right lung.
Yeah.
In a relatively young patient.
Mucus plugging could be one of the. No.
Quite a lot of mucus is required to result in.
Hypoplastic or agenous hypoplastic lung.
Much more common diagnosis is McLeod syndrome.
McLeod syndrome.
Okay, this is classical McLeod syndrome. The right lung has smaller volume. Vascular structures are normal. You can also train your eyes getting used to identifying which side is hyper-transradiant. So right lung is a bit hyper-transradiant, a bit smaller, lot less vessels. That's abnormal, and diagnosis is McLeod syndrome. Okay, chronic infection in the past, airway infection in the past resulting in obliteration of the bronchial tree. Unilateral hyper-transradiant hemithorax. Again, it's a revision. We have gone through this. We will skip to the next slide. This is all, we have done it already. Yeah, next one.
For the chest radiograph, there is abnormality on both sides of the lung. On the right side, there is a quite diffuse opacity in the right middle lobe, and the bulging of this fissure.
So I would describe it as a rather well-defined, smoothly marginated mass lesion.
Okay.
So is that not correct? Is that not the right? Yeah.
Yeah, I was thinking of this. I was thinking on the context of infection, so I was just going down that line. But you're right. Yeah, well-defined, smooth-bordered.
Smooth-bordered, large, soft tissue density mass lesion in the right lung, and there is left lung cavitating lesion. Can you see the cavity? Use this term. Yeah. So there is an abnormal opacity in the left lung which has got inner lucency. That is cavitating. That's how the term should be used. Yeah.
Yeah.
There's a cavitating lesion in the left lung. You can't take it any further. You need CT.
So on CT, on the left side, there is air. Yeah, there's air crescent sign kind of thing. There's a nodular thing, and then there's a large rim of air around the left cavitated lesion. On the right side, there's a homogeneous cystic lesion.
Yeah. Diagnosis. If you have seen this, you'll get the diagnosis.
Just wondering whether it's a hydatid cyst, but there's no.
It is hydatid cyst. It is hydatid cyst. Yeah.
I was looking for water lily sign and those daughter.
Yeah. Unfortunately, those signs were not available. Anyway, so that's a collapsed endocyst within the ectocyst. Yeah. So that's hydatid cyst. The right side cyst is not collapsed yet. Good. Hydatid cyst endemic, left lobe more than upper lobe. It has got 3 layers. Pericyst. Pericyst is human fibrous tissue that develops outside the cyst. Exocyst, which is a membrane, and endocyst, which is a germinal membrane, which makes the daughter cyst. So crescent sign can happen between the pericyst and laminated membrane. A double crescent sign or double arch sign is air crescent sign plus air between the germinal membrane and exocyst, and water lily sign is air around floating, collapsed endocyst. Next case.
CT axial slices, which is demonstrating empyema of the left.
Yeah, it is empyema.
With the sign.
Yeah, correct. So this is empyema with split pleura sign. Yeah.
Around consolidation, collapse, consolidation of the lung.
Yeah, there is consolidation and collapse in the lung. So split pleura sign is because of the infection, the visceral pleura that is here, and the parietal pleura is thickened with inflammatory soft tissue, and they both enhance because they are hyperemic because of the infection. Split pleura sign in empyema. Next case.
From the chest radiograph showing bilateral, I think Acinar shadows again, but on the right side there's a cavity.
Very good.
And this the differential is long. These could be septic emboli with the cavitation.
Will there be background consolidation in septic embolism? Bilateral?
Unlikely. Very unlikely. The differential of this appearance.
There is bilateral, predominantly mid and lower lung ground glass densities, isn't it?
Yeah.
I would describe it as ground glass because you can see the vascular structures in between.
Yeah.
You can see bronchograms, but most of the vascular structures are also present. They're not to that degree where it is obscuring the blood vessels. So we can describe it as bilateral ground glass densities, and within the ground glass density there is a cyst. There is a cyst within the ground glass density. Diagnosis?
Crown twice.
If you know it, it's pretty straightforward.
No, I probably was struggling here.
This is PCP pneumonia. Okay. So PCP pneumonia happens when there is lymphopenia, a CD4 count of less than 200. Chest X-ray shows bilateral, perihilar, granular, or ground glass opacities and air cysts. Air cysts may be present in up to quarter of cases. Pneumothorax can happen in 1/3 of the cases with air cysts. PCP pneumonia can be in the upper lobe in those people treated with aerosolized pentamidine, and lymphadenopathy and effusions are uncommon.
This is bilateral lung abnormality, bilateral scarring basically, especially in the upper lobes, more on the right side. I think there's thoracoplasty done on the right side of plumbago.
Very good, very good. Yeah. So bilateral apical fibrosis, biapical fibrosis. Differentials?
TB is top differential.
Yeah. One differential is TB, another one?
Sometimes radiation can cause it as well, but this is not very typical radiation.
Bilaterally?
No, mostly it's going to be unilateral.
Yeah. So bilateral apical fibrosis, we discussed the differentials earlier.
Yeah.
It can be TB, can be ankylosing spondylitis, it can be CWP, progressive massive fibrosis, and so on. In this case, you correctly identified an abnormal density in the right apex. Do you think what is happening here? What might have happened?
They used to. It's an old TB patient.
Very good. Yeah. So they used to put plumbage. Plumbage. They used to put some stuff in the right apex to make the cavity collapse in TB. This is our own patient, an elderly gentleman came from his TB treatment probably half a century ago. So biapical fibrosis with TB plumbage treated in the past in the right upper lobe. Yeah, this is, take a picture now, please. We have only one more session to go, which won't take more than 15 minutes. So we'll do that quickly and wind up today's session. Please take a picture of this and provide feedbacks. Feedbacks are really important. I'm going to stop sharing now and open the next session. Can the next candidate raise hand, please? That will be candidate number 4.
Yes, I'm here.
Good. Just a second. I can hear you. Now I need to bring out. This is a very quick one. Playing up. Yeah, can you see the X-ray now?
Yes, I can.
Good. Use maximum screen brightness. There are some abnormalities which may be tricky if you don't have sufficient screen brightness.
So I've got an AP radiograph in a skeletally mature.
Your voice is muffled.
AP radiograph in a skeletally mature patient, and here central normal heart size and mediastinal confidence. Both hilar points are at the same level. There's an opacity projected over the left hemithorax. Lower lobe.
Ignore that.
And I can see breast shadows on both sides.
Your voice is really muffled. What kind of device are you using to speak?
I'm just using my laptop.
Okay.
Can you hear me now?
Yeah, I can hear you, but the voice is muffled and not clear.
Is it better now?
That's better now.
So
It's
I
best to use a headphone and mic if you have one.
can see any focal collapse or consolidation. There's no mediastinal shift. Just
Can
going
you see my arrow?
No.
Right, you're right. The arrow is not projecting. Are you able to see my arrow now?
Yes, I can.
Yeah, you can see the arrow, can you?
Yes.
Yeah. So this is something, is a pass or fail X-ray. If you miss this, you're not going to pass a first year exam. This can be a rapid reporting case as well.
So
It's difficult to, look through it all of a sudden in the exam. Yeah.
apical pneumothorax.
Beg your pardon? Again, your voice is muffled.
Right apical pneumothorax?
It is, correct. It's left. Did you say right? Well, yeah. So that is the visceral pleural line. Can you see that? If you bright, you need to really, if you're not able to see it, I can see it in my screen very well. If you're not able to see it, you need to use your maximum screen brightness in a large screen. So that is pneumothorax. You need to diagnose this if you want to pass a FRCR exam. There's also a fracture in the scapula. Very unusual. There's a fracture. But look for fractures and get your eyes used to picking up visceral pleural line and the air, pneumothorax air in the apex. Always look for that. Okay?
Yep. So again, I've got a frontal radiograph on which I can see there is a difference between the transradiancy of both lungs.
Yeah.
The right lung appears more loosened, and I can see a loosened line projected around over the right mediastinum, which configures to the shape of a vessel. It's quite long, linear, and going all the way down.
So difference in transradiancy of thorax, it's not difference in transradiancy of the lungs. It's actually difference in transradiancy of thorax. You know what I mean? So there is a difference. So difference in transradiancy, one of the differentials is a pneumothorax as well. Yeah.
And I can
That's
see.
Why you should think in terms of not lungs and, difference in transradiancy of chest.
Yeah. So the right hemithorax is quite appears loosened compared to the left. Can't see any lung markings there.
Have you heard of deep sulcus sign?
Yes, I can see a deep sulcus sign on the right because I can see it goes all the way down there.
Very good. So that is a deep sulcus sign where you can see the diaphragm all the way quite low down, and that indicates a
pneumothorax.
Pneumothorax in what projection?
In a supine projection.
Yeah. So pneumothorax in supine projection, deep sulcus sign. There is another useful sign to look for associated with deep sulcus sign in supine pneumothorax, which is the superior margin of the involved diaphragm. It will be quite pristine and sharp. Can you see that?
Yes.
It's quite pristine and sharp because it is outlined just by air and not by air inside the lung.
Yeah.
Compared to the slightly fuzzy left hemidiaphragm, the right is quite sharp and clear, because it is outlined directly by just empty air and not by air in the lung. So deep sulcus sign and sharp margin of the dome of diaphragm on the same side. So there is a pneumothorax on the right side, which is what resulting in the increased transradiancy of the right chest. Is there tension?
No, I can't see any tracheal deviation.
There is no tracheal or mediastinal deviation. Always, if you report a pneumothorax, always mention the next line should be there is tension or there is no tension. Okay? Good.
So again, on this frontal radiograph, I can see the left hemidiaphragm is raised compared to the right. And there is, overlying the right chest wall, I can see there is an opacity, irregular opacity, which appears to be pleural based.
Right chest wall, pleural based opacity.
In the mid zone.
In the right chest? Are you talking about that's the scapula?
Okay, it looks slightly nodular around the...
There are nodules in the lung. That's a nodule. That's a nodule. Irregular nodules, not discrete nodules.
Both
Some
in the
irregular nodules.
So bilateral nodular opacities, predominantly in the mid and lower zones.
Yeah. Do they have any pattern in the distribution?
So yeah, they're predominantly mid and lower zones and peripheral, not perihilar. They are more peripheral based.
Right. I would just describe it as scattered nodules.
Scattered.
There are some nodules here, some nodules here. To describe it in a pattern, you know, you have seen so many cases of nodules, silicosis, sarcoidosis, subacute hypersensitivity pneumonitis. They all have a fairly symmetrical pattern. To call it in a mid-zone distribution. These are just scattered nodules, irregular nodules here and there in the lung. You can't say there's, you know, they have a pattern to it. Anyway, there's another finding which I want to pick up in this.
So I cannot see any evidence of rib destruction.
Yeah, the bones are fine.
I don't know whether there's an opacity projected in the left retrocardiac region.
Ignore that, that's fine. So again, this is about identifying the visceral pleural line. Can you see the visceral pleural line?
Yes, I think there's a left pneumothorax there.
Is it just left or is it bilateral?
Yeah, on the right. So biapical pneumothoraces with the multiple nodules, I'd be suspicious of osteosarcoma metastasis.
Yeah, correct. Osteosarcoma metastasis, biapical pneumothorax. Yeah, identify visceral pleural line. This is crucial for your rest of your life and for the exam. It's very subtle, it's tricky, but I've made the X-ray soft so that this can be picked up.
So again, on this frontal radiograph, I can see there is increased, the left lung is hyperlucent compared to the right. I can't identify any, and there's a linear opacity projected over the pleural surface on the right.
Yeah. So I'll give you a clue. This is a lateral decubitus X-ray.
So it looks like there's an air fluid level there in the right, because the upper bit looks loosened, and then as I go lower down, it appears more dense. I think there is a pneumothorax. There's an air fluid level there.
Air fluid level is pneumothorax, or what do you say air fluid level in pleural space? What's it?
Empyema. But yeah, air fluid level.
The term is hydropneumothorax.
Hydropneumothorax. Yeah.
The term is hydropneumothorax. There's no hydropneumothorax. This is a lateral decubitus X-ray showing straight effusion.
Okay.
I don't know where you see the hydropneumothorax. I'll give you the PA view first. This should have been usually first. Do you want to comment on? It's tricky. It's not easy. But if you have seen and diagnosed one of these, then that'll be there in your mind. What do you think about the right dome of diaphragm?
So the right dome of diaphragm is distant medially, but partially obscured laterally, and it's
So when you see a dome of diaphragm, where is the usual peak? Is that in the middle? Is that in the medial part? Is that in the lateral part? The peak of the diaphragm?
in the middle.
The middle. And what's happening to the right side? Is that in the middle, or is that
It's
kind
more
of off?
more lateral.
Yeah. Yeah. So that's actually a laterally peaking right dome of diaphragm. So that can happen if there is subpulmonic effusion.
Okay.
So the previous X-ray, if there is subpulmonic effusion, the dome will be elevated and look for a lateral peaking diaphragm.
Okay.
Yeah. And then nowadays we don't do lateral decubitus X-ray. The previous X-ray was a lateral decubitus to diagnose subpulmonic effusion. Nowadays, what do we do if you want to diagnose subpulmonic effusion?
We do a CT.
Really?
Well, I've
Too much
seen
radiation.
we could do an ultrasound.
Exactly. Much simpler. Just do an ultrasound. Okay. So elevated domes of diaphragm, above the causes are above diaphragm. Anything that can cause collapse, phrenic nerve palsy, splinting of diaphragm, hemiplegia, chronic pleural disease, subpulmonic effusion, diaphragmatic causes, eventration or diaphragmatic rupture, below diaphragm, pancreatitis, distended stomach, subphrenic abscess and mass. Next case.
So on this frontal radiograph, there's no focal collapse or consolidation.
Lungs are fine. Bones and soft tissues are fine.
Beneath the
Ignore
left
the heart, ignore the hyla. Yeah. Say it again.
diaphragm,
Yeah.
so there's an increased distance between the gastric bubble and the
Very good. Yeah. So there is an increased distance between the left dome of diaphragm and the gastric air bubble. So if you see that, what would you do next?
we could do a lateral.
Yeah. Yeah. Or you can take it a bit further than that. Is the gastric air bubble smooth? Is the contour smooth or irregular here?
Very smooth.
Very smooth. So what would you have been? What are the differentials?
It could be a subpulmonic effusion.
Yeah. Or
so something quite causing a uniform effect, which is why we're getting this.
yeah, it can only be a subpulmonic effusion. The other differential is a malignancy, a gastric fundic cancer, which will cause a soft tissue and push the gastric air bubble down, but that will be irregular, right? So subpulmonic effusion is the realistically only diagnosis that you need to consider. There's a lateral radiograph where there will be a flat hemidiaphragm and a sharp a dip in the case of subpulmonic effusion. Some fluid is going up the major fissure as well. So you can do a CT, you can do an ultrasound to diagnose it easily.
So again, on this frontal radiograph, I can see there's a chest and a tube inside you. Its tip in the right paratracheal region, and there is a somewhat cavitating abnormal lesion in the right lower lobe. So I'm thinking it looks like the chest drain's been misplaced because points not where the cavitating lesion is.
So are you referring to this one? Cavitation, which is the cavitation?
Yeah, and then there's mixed cavity. So there's opacification and with central lucencies, and this could be an underlying abscess as well.
Yeah, that's fine. So there is a what about that? What's happening there?
So there's airspace opacification there.
Is it airspace? Oh yeah, you can describe it. Yeah, that way. So it's quite characteristic of loculated effusion where?
So encystic loculated effusion between the fissures.
In the fissure.
Yeah.
In the fissure. Yeah.
Yeah.
Fissure is a structure between the different segments of the lung. So you don't have to say between the fissures, in the fissure, in the major fissure.
Yeah, so
Okay.
it's pleural
Yeah.
in the fissure, yeah.
Yeah, and there is consolidation, and there is probably air fluid level. When you see a horizontal level, always think of air fluid level. Okay. So there's quite a lot of stuff going on in this patient. It's most probably infection. It can be trauma as well, but you rightly said it's most probably infection. So there is probably an empyema here, and chest tubes placed to drain them. The lateral X-ray showing air fluid level. Okay, it's empyema.
Yeah.
Next one.
So on this frontal chest radiograph, I can see that there's again a chest drain in situ with its tip adjacent to the right heart border, and the right hemithorax is expanded. There's no mediastinal shift that I can see, but compared to the left.
Very good, very good. Whenever you see increased density of one hemithorax, what we have learned today, that the next thing to look at is for looking at mediastinal shift. So there is no mediastinal shift. So what are the differentials?
And again, I can see there's a airspace classification with central lucency, so a right upper lobe as an abscess in the lung. And so there's an abscess in the right upper lobe, and there's a chest drain, which the tip of which is not placed within the abscess. And then there's some subcutaneous emphysema in the right
Very
chest.
good. Yeah.
Iatrogenic because of the chest drain.
Anyway, I don't think we can appreciate any air fluid level in this case. It's only just consolidation in the extensive consolidation in the right lung.
The large cavitating lesion, because I don't see.
There's no cavity there. No, there's no cavity. I don't know which one are you referring to. Yeah.
Or is it an insisted because it's quite dense in the middle, and then I see lucency above it.
Okay, which one are you referring to? That one?
No, if you come down, yes, there. So this bit's.
No, that's not the cavity. The density of that is very similar to the density on the other side. It's not, to call it a cavity, should be a lot more lucent, and you should be able to define the walls of the cavity. Okay, just because you see a little lucency in an area of consolidation does not mean it is cavitated. It should have the walls defined. If you remember the cavities that were shown today, it will have the walls completely defined. Just because a little lucency is seen in the consolidation, they're not mathematical formulas. Lung can get consolidated a little bit non-uniformly, and some loosened area may mean that that part of lung is a little less involved. To call it a cavity, you should be able to define the walls of the cavity. Okay?
Yeah. So do you know whether
yeah.
a density adjacent to the right heart border in the middle, or whether that's a collection within the fissure again? Because.
Oh, you mean that?
Yeah.
Yeah. Well, yeah, I would have expected a much more smooth margin for that, for that to be called a minor fissure effusion. But that's fine. I mean, if you think in terms within that consolidation, within that extensive consolidation of the right lung, can there be a loculated effusion in the minor fissure? That's not a thought that can be considered too unreasonable. But there is something else that will clinch the diagnosis in this X-ray. So what's the diagnosis? What's happening? What is this? You did look at the surgical emphysema. What is this?
I don't know. So whether this is a foreign, it doesn't look like it. I've never seen something like that before.
Yeah, so it's a bullet. So that's a bullet that has gone through the lung. So all this is lung contusion.
Okay.
And that is bullet stuck in the exit wound.
Okay.
Okay. So look for things outside the chest, corners of the radiographs. Yeah, things in the abdomen. So that's what a fascia 2B is about. This is a simple, straightforward case of loculated effusion in which fissure?
In the horizontal fissure.
In the horizontal fissure. Good.
Again, we've got a right-sided hydro-pneumothorax because we've got an air fluid level and with a straight margin. And there's no tracheal shift. The right heart is obscured. and the left lung is clear. My other differential I'd also consider is there's a large unilateral, but then I can't see any.
Your voice is really muffled. I can't hear you.
So I can see an air fluid level on the right.
Yeah.
Which appears to be like a hydropneumothorax on the right side. There's no shift, no mediastinal shift. The left lung is unremarkable. I cannot see any rib abnormalities there.
Right. There is quite a lot more to it, more to what you have said in this X-ray. So when you say hydropneumothorax, can you see any normal lung tissue at all in the right chest?
The lower zone is almost entirely opacified. Just the right.
Can you see any normal lung tissue in the right chest at all?
The right.
Yes or no answer. Sorry, I'm not.
No.
Too strong. Yeah. So there's no lung in the right chest. And can you see the clips?
Yes, I can see them now. Yeah. So
okay, good. So what is happening here?
So this patient's had a previous surgery, and post-surgical they've developed what we call.
So this, if you know it, you know it. Otherwise, there's no way to guess it or arrive at a diagnosis. So I'm going to show you. So keep that abnormalities in mind. Air bubbles, air fluid levels, and I'm going to show you the next X-ray. The next X-ray is an X-ray taken a week prior to the previous one. Does that clinch any diagnosis for you?
So whether this is a reaccumulation pulmonary, which happens post surgery when the entire lung is replaced by fluid.
Good. What is that called? Post-pneumonectomy.
Yeah, post-pneumonectomy, and then there's a re-expansion of the lung, which gives you.
If you remove the lung, then how can lung re-expand? There's no lung there.
Re-expansion of the surgical cavity with diffusion, and then it.
Okay. So what is happening here is that in a setting of a pneumonectomy, gradually fluid should accumulate and occupy the entire chest. Now, if you look at this X-ray and apply what you learned today, what is a completely opaque hemithorax or mostly opaque hemithorax, how do you take it forward? The first thing you look at is mediastinal shift is present or not. So there is mediastinal shift to the same side. Trachea is shifted to the same side. So this is either total collapse or agenesis or post-pneumonectomy. Okay, in post-pneumonectomy, gradually fluid should accumulate and fill the entire chest. But at some point in time, if fluid is receding and if air is increasing, then that's not normal. That's a complication, and that is suggestive of either a bronchopleural fistula or an empyema. So this is what should happen in a post-pneumonectomy period. First 24 hours, so mediastinum shifts towards the post-op side, and pleural space contains only air. And then gradually fluid accumulates. By 1 to 4 months, there's only fluid in the space. Now return of the shifted mediastinum into midline is a complication which can be BPF, a dehiscence of the clips, or recurrent tumor, or pneumothorax. Now air bubbles and drop in the fluid in the early postoperative period is a complication which can be a dehiscence of the pleural clips, or not pleural clips, bronchial clips, or BPF or empyema. So that's what's happened here. If you go to this first X-ray, this is a week after the second one. So second one, the fluid is gradually accumulating, but then a week later, the fluid drops and air bubbles appear. That is because either there is a bronchopleural fistula or there is the bronchial clips that was put here, that they started developing leak. Or there is empyema. Okay, so this is how it appears in immediate post-pneumonectomy period. There is big airspace. There's no lung there now, so you won't see any lung vascular markings. Just an empty airspace. The mediastinum has shifted to that side, and a little bit of fluid is accumulating, and then gradually fluid is accumulating. Still some empty spaces there, airspace is there, and then gradually fluid accumulates and replaces the entire left chest or entire chest where the surgery was done. Okay, So sometimes it can happen fast, like in this patient. In 13 days, the entire left hemithorax where the lung was removed is filled with fluid and the mediastinum has shifted to the same side. Next one. I will give you CT straight away for this case.
So there is a right lower lobe pleural-based mass, which shows uniform enhancement. My differentials for this, there's no mediastinal shift, the left lung is clear, and on these soft tissue windows, I cannot see any evidence of destruction where the mass lies. So most likely differential would be a pleural fibroma.
Very good, yeah. So how did you reach that diagnosis? There is something that clinches the diagnosis here.
Has this been biopsied?
Well, I don't have the histology with me. From the CT pictures, there is something that can clinch the diagnosis.
So it's quite well defined and shows uniform enhancement and makes an obtuse angle with the chest wall.
That's all fine. There is one thing that clinches the diagnosis. Have you got that? What about the position of the mass in different patient positions?
It doesn't change.
Do you mean it doesn't?
Yes.
So here, when the patient is decupitous, the mass has shifted to anterior or posterior? The mass is which posterior chest or anterior chest in the supine position?
So in the supine, it is posterior, but in the decubitus, it's gone anterior.
Yeah. So why does that happen?
Whether it's peduncle, no, it doesn't look pedunculated.
It is pedunculated. Not that you can't see the peduncle. You may not be always able to see the peduncle. That's the peduncle there. That's the peduncle there. That's where it is attached to the pleura. That's where it is attached, and then it is just hanging on that peduncle. So when the patient is decupitous or prone, it just moves forward, and the patient is supine, it just moves back.
Yes.
So look for positions. Look for these clues beyond what is obvious to you. That's how it works in FRCR2B. But then if you don't know it, then you won't be able to apply. So that's the whole purpose of this teaching. So if you see a pleural mass, see if it is changing position. If it is changing position, that's diagnostic of a pleural fibroma. So all this pleural, this is quite straightforward. I'll just mention the pleural fibroma. It's nowadays called solitary fibrous tumor of the pleura because they like changing names and confusing us. 20% contains malignant elements, smooth lobular mass. It can go up to very large size, rising from the visceral pleura more than the parietal pleura, and they change position. And there is a chance of hypertrophic osteoarthropathy.
So on this frontal chest radiograph, I can see there is a pleural thickening, which appears to be extending to the mediastinal pleura, and it's a nodular pleural thickening with an
diagnosis
mesothelioma.
Yeah, mesothelioma, nodular pleural thickening, and dense hemithorax, quite characteristic of mesothelioma. Good. So that's the CT of the same patient, soft tissue thickening of the visceral as well as parietal pleura and along the fissures as well.
There's a left-sided pleural, so there's a unilateral pleural effusion and what I take to be extensive pleural plaques.
It is extensive pleural plaques. Somebody was looking at a calcified fibrothorax and confusing it with pleural plaques. This is how pleural plaques look like. They look like marginally calcified, leafy-like abnormalities on X-ray. That's a leafy-like marginal calcification, and inside is a kind of amorphous calcification. This is how typical pleural plaques looks like. Get your eyes used to seeing pleural plaques. And in addition,
there's a mesothelioma because there's pleural thickening, a unilateral.
Exactly, very good. Pleural effusion and pleural thickening. Can you see that?
Yes.
Very good. So that's asbestos exposure leading to mesothelioma. So you can see CT pleural blocks, and you can see nodular soft tissue thickening. Okay, that's done. Thank you. So can you do the feedback? Really important if you haven't done so already.